Welcome back to Merit 360. This is part 2 of my lecture on the types of diabetes. If you haven't watched part 1 yet, I highly recommend checking it out first, where I explain type 1 diabetes in detail. The video got long, so I decided to break it into parts. In this video, I will be discussing type 2 diabetes and other less common types. Type 2 diabetes mellitus is a heterogeneous chronic metabolic disorder. The pathogenesis of type 2 diabetes mellitus is different from that of type 1, and it is multifactorial and complex. Unlike type 1 diabetes, type 2 diabetes mellitus has a very strong genetic predisposition, that is 90% concordance rate for identical twins. This means that if one twin has the disease, there is a 90% chance that the other twin will also develop it. This suggests a strong genetic component in type 2 diabetes, but the environmental factors like diet, lifestyles also play a role, and which will be discussed later on. On the other hand, the type 1 diabetes has a weaker genetic influence and only has about 30 to 60% concordance for identical twins. This means that type 2 diabetes mellitus has a very strong genetic predisposition as compared to type 1 diabetes. Okay, now let's discuss the genetics of type 2 diabetes mellitus. Type 2 diabetes mellitus has a polygenic inheritance, meaning that multiple genes contribute to the risk of developing type 2 diabetes, rather than a single defective gene causing the disease. Many genes, over 400 genetic loci, have been identified which are involved, each having a small effect on increasing or decreasing the diabetic risk. This is in contrast to the monogenic diabetes like MODY, maturity onset diabetes of the young, which is caused by a single gene mutation. So type 2 diabetes mellitus, it is a polygenic, depends on both genetics and lifestyle, including diet, physical activity and obesity. That's why someone with a high genetic risk may not develop diabetes if they maintain a healthy lifestyle, while someone with a low genetic risk might develop diabetes due to poor lifestyle choices. All of this explains why type 2 diabetes clusters in families but doesn't follow a simple inheritance pattern. So, to summarize, type 2 diabetes doesn't develop due to genetics alone, nor is it purely a result of lifestyle choices. Instead, it is a combination of both a strong genetic background with superimposed on acquired factors leading to the disease onset. A person with a high genetic risk may not develop diabetes if they maintain a healthy lifestyle. However, when additional factors like obesity, stress, pregnancy, or long term glucocorticoid use come into play, they can tip the balance, leading to the development of type 2 diabetes mellitus. This explains why some people with a family history of diabetes remain disease free, while others, even with moderate risk, develop it due to poor lifestyle habits. So, both genetic predisposition and environmental triggers play a crucial role, reinforcing the importance of prevention through healthy habits, especially for those with a strong family history. I hope you now have a better understanding of the complex pathogenesis of type 2 diabetes. I have tried to explain it in the simplest way possible, breaking down how genetics and environmental factors work together in its development. Now that I have explained how genetic and environmental factors contribute to the type 2 diabetes, let's dive into the pathophysiology of type 2 diabetes mellitus. What actually happens in the body that leads to this condition? In the pathophysiology of type 2 diabetes mellitus, three organs are at the center of the disease process. These organs include liver, pancreas, and muscles. Insulin resistance develops in the liver and the muscles, and progressive beta cell failure occurs in the pancreas. Now let's discuss each of these three mechanisms. When there is insulin resistance in the liver, instead of the normal function, the liver starts to produce excess glucose, even when the blood glucose is high. This results in hyperglycemia. Similarly, there is insulin resistance in the muscles as well, which leads to impaired uptake of glucose by the muscles, resulting in hyperglycemia. And now, what happens in the pancreas is that the body and the organs have developed insulin resistance and they require more and more insulin. Initially, the pancreas compensates by producing more insulin, but eventually it fails, leading to insulin deficiency. So, over time, pancreatic beta cells struggle to keep up with the higher demands and results in relative insulin deficiency. So, to recap, in a person with genetic susceptibility plus the environmental factors, the pathophysiology of type 2 diabetes mellitus include the classic triad of insulin resistance in the liver, resulting in excess hepatic glucose production. Number 2, insulin resistance in the muscles, resulting in impaired glucose uptake. And number 3, the progressive beta cell failure, resulting in relative insulin deficiency. This is the classic triad of pathophysiology of type 2 diabetes mellitus. If you think that I'm done with the pathophysiology of type 2 diabetes, you are so wrong. So far, we have talked about the three main organs involved in the type 2 diabetes. These are the pancreatic beta cells, liver, and muscles. But there is more to the story. In 2009, Dr. DiFronzo introduced the concept of the ominous octet, highlighting five additional players that drive diabetes progression. These include the fat cells, the GI tract, the pancreatic alpha cells, kidneys, and the brain. As we have already discussed, the pancreatic beta cells dysfunction leads to relative insulin deficiency. The insulin resistance in the liver results in excess glucose production, and the insulin resistance in the muscle results in impaired glucose uptake by the muscles. Now, what about the fat cells? How they contribute to diabetes? In the fat cells, there is increased lipolysis, leading to the excess breakdown of triglycerides into free fatty acids. These free fatty acids not only contribute to the insulin resistance in the muscles and the liver, but also promote inflammation, further impairing glucose metabolism. Next, the gastrointestinal tract. Normally, incretin hormones like glucagon like peptide 1, they stimulate insulin release after meals. But in diabetes, their secretion is reduced, leading to weaker insulin responses and higher blood glucose levels. Then comes the pancreatic alpha cells. Instead of lowering glucagon levels in response to high blood sugar, these cells become dysregulated, releasing excessive glucagon. This signals the liver to keep producing glucose even when it's not needed, further worsening hyperglycemia. Now, the kidneys. In a healthy body, excess glucose is filtered and excreted through urine. However, in diabetes, the kidneys increase the glucose reabsorption by upregulating the sodium glucose cotransporters 2, preventing the glucose from being cleared from the body and leading to persistent high blood sugar. And now, finally, the brain. Normally, insulin helps regulate appetite and metabolism, but in diabetes, the brain becomes resistant to insulin's effect, leading to increased hunger, weight gain, and impaired glucose regulation. All of these mechanisms they work together, worsening the insulin resistance and hyperglycemia over time. Understanding the ominous octet allows for better, more targeted treatment strategies, including medications that address the insulin resistance. So, this was all about the pathophysiology of type 2 diabetes mellitus. I hope that it was entertaining and informative as well. So far we have explored type 2 diabetes in detail, its etiology, the pathogenesis, and the pathophysiology. But to really cement our understanding, let's take a step back and compare type 2 diabetes with type 1 diabetes. This side by side comparison will not only help us to appreciate the differences, but also highlight the unique challenges faced by people living with either condition. Let's start with the proportion of cases involved. This is a big one. Type 1 diabetes make up only about 5% of all diabetes cases, whereas type 2 diabetes accounts for a whopping 95%. That means that for every one person with type 1 diabetes, there are 19 other dealing with type 2 diabetes. That's a huge public health burden. Next, let's talk about the age of presentation. Type 1 diabetes typically appear in young individuals, often under 30 years of age. You can easily imagine a child suddenly developing excessive thirst, unexplained weight loss, and fatigue, classic symptoms of type 1 diabetes. On the other hand, type 2 diabetes is more of an adult onset disease, often diagnosed after the age of 40. However, with rising obesity rates and sedentary lifestyles, we now are seeing type 2 diabetes creeping into younger age group as well. Now what about weight? Here's where the two conditions take very different paths. People with type 1 diabetes are usually normal or even underweight at the time of diagnosis. Their bodies are simply unable to produce insulin, leading to uncontrolled blood sugar levels and weight loss. In contrast, obesity is a major risk factor for type 2 diabetes. Excess fat, especially around the abdomen, drives insulin resistance, making it harder for the body to use insulin effectively. Family history. It also plays an interesting role. Type 1 diabetes is often sporadic, meaning there's usually no strong family history. It's an autoimmune condition where the body mistakenly attacks its insulin producing cells. But in type 2 diabetes, genetics play a major role. If you have a strong family history of type 2 diabetes, your risk is significantly higher. So, if multiple family members have diabetes, it's a wake up call to focus on lifestyle modifications early on in the life. Now, what about the risk of developing diabetes type 1 and type 2 in identical twins? The concordance for type 1 diabetes is 30 to 70%, and that for type 2 diabetes is 90%. Type 2 diabetes has a stronger genetic component. If one identical twin has type 2 diabetes, the concordant rate is 90%. This means that there is a 90% chance that the identical twin will also get diabetes. This is a very high rate. Now let's move on to pathogenesis and pathophysiology. What actually causes these conditions? The type 1 diabetes results from absolute insulin deficiency, in which the immune system mistakenly destroys the pancreatic beta cells, leaving the body with no insulin production. That's why people with type 1 diabetes must take insulin to survive. On the other hand, type 2 diabetes is a combination of insulin resistance and insulin deficiency. Initially, the pancreatic beta cells they compensate by producing more insulin, but over time it struggles to keep up with the higher demands, leading to rising blood sugar levels. One very important key distinction in both of these is the presence of autoimmune markers. Type 1 diabetes is an autoimmune disease, and we can detect markers like anti-glutamine acid decarboxylase, anti-GAD antibodies, or anti-insulin antibodies, or anti-islet antigen antibodies. On the other hand, there are no autoimmune markers in type 2 diabetes because it is not an autoimmune disease in nature. Instead, it's driven by genetics, lifestyle, and metabolic factors. Now, another crucial point is the response to insulin. Type 1 diabetics, these are insulin sensitive, meaning they respond well to insulin therapy. But type 2 diabetic patients are typically insulin resistant. Their bodies produce insulin but their cells don't respond properly, requiring higher doses of insulin or additional medications. Now, finally, let's talk about treatment. Type 1 diabetes require insulin for survival. There's no alternative. In type 2 diabetes, management includes diet, lifestyle changes, oral anti-diabetic medications, and sometimes insulin if the blood sugar remains uncontrolled. So, in summary, while both conditions affect the blood sugar regulation, their causes, risk factors, and the treatments are vastly different. Understanding these differences not only help in the diagnosis and the management, but also in the spreading awareness of these conditions. And I think that's it for today. In this lecture, I have covered type 2 diabetes in detail and compared it with type 1 diabetes to give a clear understanding of both. But we are not stopping here. In the next part of this video, I will be diving into the less common types of diabetes, some of which you may have never even heard of before. So it's going to be fascinating and you don't want to miss that lecture. Now in the end, I want to hear from you as well. Did you find this video helpful? Or do you have any specific questions about diabetes that you would like me to cover next? Let me know in the comments below. And of course, if you like this video, hit that like button, subscribe for more medical insights, and share this with anyone who might find it useful. Thank you for watching, and I will see you in the next one. Stay blessed, stay healthy. Goodbye.